שיהיה לנו בוקר כיפי ומלמד. דבר שני, רציתי להגיד תודה ליאיר מורד שעזר בארגון הכנס ולהביא את המרצה ולתת לנו את העולם והמון דברים. אז תודה רבה יאיר. רציתי להגיד גם תודה לאופטיקות שנתנו לנו חסות היום ובעצם אפשרו לנו להביא את המרצה מארצות הברית. אופטיקה מולג'ו, אופטיקה חדשה שיושבת בתל אביב, אופטיקה אופטיקית שכולנו מכירים עם כמה סניפים בארץ, ואופטיקה טרופיק שלנו מירושלים, שהם בעצם לא פיזית פה אבל הם בלב. היה מתוכנן לתת לכם כמה עדכונים, אבל הוחלט רגע האחרון שאנחנו נשלח את זה במייל. ואנחנו רוצים להגיד welcome to Irene Ludwig. She's our guest speaker today, and Yair is going to introduce her. So thank Irene for coming.
Good morning, everybody. It gives me great pleasure to introduce Dr. Irene Ludwig to you. Irene really is a good friend, and I'm really happy that she came to us to Israel. Her fine qualities were apparent even since elementary school, when she was selected out of thousands of students to attend the prestigious high school program in New York City. And she had to commute a long distance every day on the subway from her house to the school. And since then, she found out that the best place for her to learn and concentrate is on a moving train. And whenever she wanted, if she really liked to concentrate, she just get on a train and get the things done. She later finished medical school in Cornell University in New York and started a residency program in general surgery. But very quickly she found out that maybe ophthalmology is better, and since then she is an ophthalmologist. She finished residency in Cleveland and was very fortunate to work with Marshall Parks, the father of pediatric ophthalmology in Washington, D.C., and she learned a lot from him, as you all know. Today, Irene divides her time between Nashville and Alabama doing surgery and teaching. And she's really very, very busy, even today. I first knew Irene's work while I was preparing a talk for the WSPOS meeting in Barcelona way back in 2009. The subject of my talk was consecutive exotropia. And I came across her paper about stressed cars, which was really fabulous. It was so convincing and well organized. And it really changed the way I treat patients with consecutive exotropia since. And when I met her in several meetings in the States, I realized that she has other out-of-the-box, new, interesting idea. And I decided that we need to bring her over to Israel so we could all learn from her and try to understand the new concepts that she's talking about. And I'm sure you'll find her talk really fascinating. So Irene, please.
Okay, I'm starting with actually the most complicated and long talk, which is, to me, the most interesting, and it's still a work in progress. When I think, the way I think about the creative process in medicine are two basic types of research, and most of what's done is planned research. We have a problem, we throw resources into finding the answer. And the HIV/AIDS epidemic was a classic example of this. There was a lot of creativity was required to find the solution, to study what the cause was, but the subject matter that was being studied was not by chance. But then there's the chance observational research. If you observe a phenomenon and the observer takes it where it leads, the study finds the researcher. He or she cannot choose it. Paradigm shifts can come from this approach, but so does controversy. And then there's, of course, combining the two. You know, when you're doing planned research, you may come across an unexpected finding. Lots of NASA research led to other developments, and that can detour you to a new area of study. And then while you're doing chance observational research, you often have to do a lot of planned research to analyze and confirm your results. So it's a mix. And it's funny, but I should use the pointer, I guess. When people hear you talk about research, they expect that it was just a gradual gathering of data, progressively increasing your understanding, so over time your understanding improves, as on the left. But the reality is on the right. When you're doing chance observational research, it throws you every which way. You think you've got one answer, and then you go to the other direction, and it's back and forth and completely chaotic. So with flap tear, this has been a 23-year process with periodic changes in understanding as each pivotal patient forced a change of thinking and approach. When I try to explain my understanding about flap tear, listeners are often skeptical. It seems to them that the ideas have come out of left field. I make broad statements which do not seem substantiated. Working outside an academic institution the last 15 years has afforded me the luxury of time to investigate and confirm my results without the pressure of producing frequent publications. By the time I do present the material, I have become convinced of its veracity. In the few minutes allotted in normal presentations, there is insufficient time to take the audience through the 23 years of understanding and observation which have led to my current understanding. This lecture today is a good opportunity to do just that. So rather than thinking of this as a lecture, however, I'd like to call this a story. I will tell you the story of flap tear as it evolved from the first case in 1994 to the very recent cases which have forced further changes in understanding. This is still a work in progress. I don't have all the answers yet, and hope that some of you will take this farther. There have been many cases, and I'm not analyzing them all today. Instead, I will tell you the story of each pivotal case who turned the thinking into a new direction. My goal in telling this story is to stimulate all of you to think about these muscle and pulley traumas and to look for them in your own practices. I hope you will see that I've had no choice in this study. It found me, and I simply followed it where it led. So we start with the first case. A 23-year-old man was struck on the left orbital rim during an attack in August 1993. He experienced diplopia and was seen by a well-respected general ophthalmologist who noticed inability to infraduct the left eye. There was also paresthesia of the infraorbital nerve. The CT scan showed a shattered orbital floor with entrapment of the inferior rectus. There was also a medial wall fracture and medial displacement. The orbital floor was repaired by that ophthalmologist 10 days after injury with a med-core plate. He was still noticing diplopia on his first postoperative day, which just did not improve over time. He had a left hypertropia of 15 at 6 months, and therefore that ophthalmologist recessed the left superior rectus 5 millimeters. 10 days later, he still had a left hypertropia, which persisted for 3 months and was worse on down gaze. He was referred to me. So I saw him a year after the trauma. He was able to fuse with a chin down position and a little bit if he worked hard in primary position, but was very bothered by diplopia in down gaze and worse in left gaze. And these were his measurements. So you see he has a left hypertropia worse on left gaze. It's the opposite of what you'd see with a fourth nerve palsy. And he had under depression of the left eye. And I repeated his measurements a few times, and it was about the same. There was no torsion on fundus exam. He had seen another strabismus specialist also, who I knew, and so we talked on the phone, and he had done forced duction. He found severe restriction on up and down gaze. Now, I had been taught in training that a down gaze deficiency after trauma was due to injury to the branch of the third cranial nerve to the inferior rectus. This was the first such case I had encountered, so I reviewed the anatomy of that area to determine exactly where such an injury could occur. I could not find an anatomic location where the inferior division of the third cranial nerve to the inferior rectus could be severed without going through the muscle itself. I therefore suspected a lost, slipped, or transected left inferior rectus, or a severe fibrosis of the left superior rectus causing the decreased depression. In the operating room, preoperatively, right before surgery, I performed force generation tests. I wanted to test the strength of the inferior rectus, and it was strong. So holding the eye while in primary position and asking him to try to look down, I felt a very good solid pull. Under anesthesia, force duction testing showed restriction to elevation and depression in the left eye. I expected that the left inferior rectus would be off the eye, but when I hooked the muscle through the infranasal fornix incision, its insertion was in the normal position. I was actually kind of shocked. There's something wrong with the muscle, though. I literally sat there for 3 hours, looking at that muscle and gently picking at the tissues. The muscle insertion was thin and narrow, and the anatomy seemed distorted. There was a dense mass of fibrous tissue inferior and external to the inferior rectus, and after picking apart at the tissues very gently, suddenly a large flap of tissue came forward, and the anatomy became clear. It was a big chunk of the inferior rectus was off the eye and scarred into the wrong direction, basically towards the inferior orbital rim. The belly of the inferior oblique was also damaged and fibrosed, and I repaired that. And when I was finished, it looked like the normal anatomy had been restored. It looked like a flap of the muscle had been sliced off the insertion, and I attributed that to the orbital surgeon. I figured he had sliced the muscle when he was doing his orbital repair, and the other possibility was that the assailant had used a penetrating object at the time, slicing the muscle. Fortunately, I did not express my opinion about the orbital surgery, as it could have easily led to an undeserved lawsuit. On the first day, he did not appear much improved and still had underdepression of the eye, and I recommended that he start exercising his motility by rotating his eye up and down. 1 month later, the depression was improved and he could lower his eyes further and he could walk around without diplopia. 3 months postoperatively, his head position was improved, and these were his measurements. 9 months later, his functioning had improved a great deal, and he was now down to a left hyper of 5 and down gaze, and he was back to doing sports. And 3 years later, he only noticed diplopia when he was in extreme down gaze, such as lying down in bed watching television, but he was functionally without diplopia. So at that point, I concluded that a partial injury of the inferior rectus can occur as a complication of orbital floor fracture repair, and that this was due to the orbital surgeon slicing the muscle, creating a tether, which causes a hyperdeviation and a down gaze restriction. The restriction is present on force duction testing, and force generation testing will show normal muscle strength, proving it's not a palsied nerve. Over the next 4 years, I collected another 4 cases of flap tear following orbital floor fracture repair, and I considered this an iatrogenic complication, which I reported as a poster at the Academy of Ophthalmology in 1998. I was convinced that the orbital surgeons were causing this until a child showed up in the office. And this was a 6-year-old boy who was playing with his sister, who pushed him into a table. He struck the right inferior orbital rim and showed it immediately to his mother, who saw no bruising or other problem. He seemed a little quieter than normal for 2 days and then returned to normal. But after a week or two, his mother began to see a right head tilt. She brought him to his optometrist, who sent him right to me. He had a right head tilt, no ophthalmos, and this is him. But he had a right hypertropia in primary, left hypertropia on up gaze, and a large right hypertropia in down gaze. And he had 4- elevation and depression of the right eye, with an A-pattern exotropia, which became more noticeable on down gaze. And this is his right eye and up and down gaze. So I got a CT scan of his orbits. He had 400 seconds of stereo, and he had in-cyclotorsion of the right eye, not an X-cyclo. His CT scan showed a minimally displaced orbital floor fracture with entrapment of the inferior rectus. So I went in on surgery with the orbital surgeon together. And his force duction showed marked resistance to elevation and moderate resistance to depression of the right eye. We repaired the orbit first, and I watched his approach carefully. He was very posterior, nowhere near the inferior rectus insertion. The muscle wasn't trapped posteriorly, it was easily freed, and the plate was placed without difficulty. Force duction showed improved elevation, but there was persistent resistance to depression. So then I approached the inferior rectus through an infratemporal fornix incision. There was a thinned and narrowed insertion with avulsion of the nasal 2/3 of the inferior rectus from the insertion. So here's his inferior rectus. Can you guys see the pointer? Yeah. Here's the inferior rectus. This is the normal part of muscle. This is the intact capsule. This whole chunk is missing right here. It looks like a divot. And the retractor, the Damar retractor, is up in here somewhere. And this is the tissue right here that has been avulsed. And there's the flap after I freed it up from the scarring to the orbital soft connective tissue. And I put a suture through the end of the flap. The flap was very anterior. It was nowhere near the fracture site or the work of the orbital surgeon. It was clear that the flap tear had been caused by the original trauma and was not iatrogenic. I put the flap back in the original. This is that same muscle with the flap back on the original insertion. And then I used a free Tenon's graft from the supratemporal quadrant to resurface the muscle. At the first time I saw him after surgery, he was orthotropic in primary position and a small right hyper and down gaze, which resolved, the right hyper resolved by 6 weeks postoperatively. Here he is at a couple weeks post-op. Up gaze, still a little entrapment, but down gaze is already much improved, and by, after a short period of time, he was completely asymptomatic. So now it was clear that flap tear was a complication of orbital fracture and not iatrogenic. I was at the Kostenbader meeting shortly thereafter, and they were presenting a case that sounded similar, so I brought up my case, and David Stager Sr. got up and said that reminded him of the global and orbital muscle layers which had recently been described by Joe Diemer. Could the pulleys be playing a role? Could the attachments of the orbital layer of the inferior rectus to the orbital connective tissue in the muscle cause an avulsion at the time of the orbital floor fracture? So this was at the time my hypothesized mechanism. These arrows are wrong. The artist did it wrong. The force is on the orbital rim. The force is on the orbital rim, and when the fracture develops, the septi are pulled into the maxillary sinus, dragging the outer layer of the inferior rectus with it. And then if the flap heals in a direction towards the orbital rim, the eye won't be able to look down. So a number of cases of hypertropia with ipsilateral orbital floor fracture were seen over the next several years. It became clear that there was a much better motility and alignment in those without fracture repair or with simultaneous muscle and fracture repair than in those whose fractures were repaired first before addressing the strabismus. Here's another simultaneous repair. This child had an orbital fracture on his right eye, and this is his down gaze. And after repairing it together with that same orbital surgeon, full return of motility. So prior orbital floor fracture repair reduces effectiveness of flap tear repair. This was where I was at the time. Why is that? So my conclusion is that we should try to get at these muscles before the orbital surgeon or together with the orbital surgeon. Then another patient came in, a 36-year-old off-duty policeman was struck on the back of his head on actually New Year's Eve and fell forward on the pavement, losing consciousness. His memory returned 2 days later, and he recalled diplopia as soon as he awoke. He had a normal brain MRI scan immediately following the trauma and came to me by January 13th, so very shortly after the injury. He had esophoria in primary position, but a left hypertropia in down gaze, and what looked like underacting left superior oblique. He did not want a dilated exam that day, so I told him he had an acute left fourth cranial nerve palsy and that I would see him in 2 weeks. He thought maybe he was a little better, but his measurements did not agree with him. He still had a left hyper of 18 on down gaze and esophoria in primary position and what looked like an underacting left superior oblique. But when I dilated him that day, there was no fun distortion, and you cannot diagnose superior oblique palsy without excyclotorsion. So on closer inspection, I noticed that his left eye was not depressing fully in AD or abduction. I ordered an MRI scan of his orbits and brain with special attention to the inferior rectus of the left eye. The scan was read as normal. There was no fracture, no muscle asymmetry. I could not detect an abnormality either. I brought him to surgery 2 months later, and on initial appearance, there was orbital fat adherent to the surface of the inferior rectus. A tear in the posterior Tenon's capsule was identified. The muscle, the inferior rectus capsule, was defective beginning at the musculotendinous junction, and the muscle appeared thinned. The insertion was intact. There was a very small flap tear of the inferior rectus found, which was seen to distort the bulging orbital fat. I freed the flap, reattached it at the insertion. This literally took 10 to 15 minutes. And I repaired the rent in Tenon's capsule. And a week post-operatively, he said he was improved, but had diplopia on down gaze. He had a left hyper of 10. By 5 weeks, he thought he was 95% improved, and he was ortho in up and down gaze, and he was asymptomatic 2 years later and had completely normal motility. So now it was clear that flap tear can be due to blunt orbital trauma with or without orbital fracture, independent of prior orbital surgery. The motility defect is still, I'm thinking, in the direction of action of the inferior rectus due to a tether effect. And then I started seeing another group of patients, which were patients who had prior retinal detachment surgery. 5 had involvement of an inferior rectus, 1 had involvement of the medial rectus, and all had a lamellar dehiscence of the muscle. So the muscle appeared thinned. So here you see this is I think it's a medial rectus. So here's the insertion, which looks okay, but there's no capsule. It's just a naked muscle. Capsule stops here. And if you look closely, this is the Damara retractor here. And these are muscle fibers right here. This is the external layer of the muscle. And this I would call a lamellar tear. 4 of the 6 muscles showed gaze restriction away from the action of the muscle, so pseudo-entrapment. And 2 showed restriction toward the direction of action of muscle, or a tether effect. So all required more than flap tear repair to correct the alignment because these were long-standing strabismus. So now I was concluding that flap tear can be caused by traction on the muscle during stripping of the capsule at the time of retinal detachment repair. And depending upon the direction of healing of the flap, the motility could be affected toward the action of the muscle, so tether, or away from the action of the muscle, or a pseudo-entrapment. So presumably, if a flap heals in a neutral position, motility might be normal. And then a 46-year-old patient came with a 20-year history of exotropia. And he insisted that his eyes had been straight. He had normal motility until he was 26, when he fell face first, flat on his face on a concrete floor at work, striking the left brow area. His exotropia began shortly following the trauma and increased over the years. He had a large exotropia, he had a right hypertropia, greater on right gaze. He had encyclotorsion of both retinas, and he had what looked like overacting superior obliques. So I recessed his lateral recti, and I recessed his superior obliques. After surgery, he was a little better, but not great. He had exotropia, distance still had a small right hyper, and he had a little convergence insufficiency. By 2 months later, his exotropia was worse. By 5 months, I repeated the surgery, and now I was knowing about flap tears. Now I'm looking at the medial recti. I explored the medial recti, and he had flap tears on both. the left larger than the right, so I fixed them. And that's all I did. And right after that, he was esotropic, he was esophoric by 3 weeks later, and by 3 months later, he was orthotropic with still a little convergence insufficiency. Why, you will know in a little while. So now I'm concluding that flap tears of the medial recti can cause exotropia with convergence insufficiency. And perhaps this explains recurrence of exotropia in some patients after standard lateral rectus recessions. So when patients insist that trauma caused their strabismus, we should listen. I did not believe him. And a 79-year-old woman was referred for treatment of Brown syndrome or supraoblique palsy. The referring doctor was not sure which. She had diplopia immediately. She was working in her garden and a branch struck her left eye. There was no loss of vision, no redness, no swelling, so she waited a few weeks before seeing an optometrist, and she only had a past surgery of cataract extractions. This was her alignment 9 months after the trauma. So she had a right, remember it was the left eye that was struck. She had a right hyper greater on up gaze with esotropia, and she had under elevation of the left eye, but normal from primary position, but normal elevation in adduction. So again, the opposite of what you'd see in a Brown syndrome. At surgery, there was a marked resistance to upward movement of the left eye, and she had a 1/3 dehiscence of the nasal 1/3 of the left superior rectus. It was stuck in the orbital connective tissue, freed and reattached. There was also a central tear. Sometimes these are in multiple pieces. Her upgaze was improved, but still a little restricted, so at the same surgery, recessed her left inferior rectus. And after surgery, she would still have a small, she actually had overcorrected her. So I had to go back and advance the left inferior rectus, and at repeat surgery, her left superior oblique was stuck to the superior rectus. So I freed the superior oblique and advanced it a little, and she was happy from then on. She had a small esophoria remaining, and we controlled that with horizontal prism. So now I realize that blunt trauma near a muscle insertion can cause a partial avulsion and tether type motility defect of any rectus muscle. The inferior and medial rectus tears are much more common due to their proximity to the ethmoid and maxillary sinuses, but superior rectus flap tear is also possible. I've seen several since that lady, but they are rare. Then another patient came in, a 22-year-old man with increasing exotropia since age 11. No family history of strabismus, eyes were totally straight before 11. He began playing football at that age and had numerous blows, American football, and had numerous blows to the face. And here was his alignment, exotropia with a V pattern, exotropia with a V pattern, and right hypertropia greater on left gaze, but a left hypertropia at near. He had excyclotorsion in both eyes. He had what looked like overacting inferior obliques. And here he is. Here's his adduction is limited. And that was on both sides. So I explored the medial recti, found bilateral flap tears, fixed them. The inferior recti also had large tears, and I recessed his inferior obliques. And he was definitely better. He was, after surgery, small XT. And that's all I had done. I had not done any resections of any muscles. But 2 months later, he was worse. By 3 months later, he was a lot worse. I recessed his lateral recti. And again, you'll find out why. That this is something that took me a while to learn about. But here's his medial rectus before repair. So you see here, this is all the muscle that remains on the eye. This little sliver here. All the rest of the bottom is missing. And there's the piece after I found it and put it back on. And I've gotten better at these where I can retain the capsule. I don't do free Tenon's grafts anymore. So over time after surgery, it took a while, but I was able to, over years, again, he had some recurrences, all related to sinusitis. But by 7 years after the original surgery, I got him, he was ortho in all directions, and now he had 50 seconds of stereo. He had no set stereo.